So my presentation is going to be about primarily in healthcare, in the domain of healthcare user interface and user experience. Particularly, topic that's of interest to me is evaluation of the anesthesia-related perioperative scheduling and management using the EPIC electronic health record, and trying to interpret the barriers in the user interface and user experience in appropriate usage of that system, especially when it pertains to anesthesia. I was mentored by Dr. Bloom, who's on this presentation as well. So the objectives of this presentation will be to understand the background and why we think this is important, an overview of the procedure sites that we assessed throughout the University of Miami system and the issues that we wanted to investigate, and then describe possible solutions, and then also discuss the next steps. So a little bit of background. For this project, we wanted to investigate the workflow in the anesthesia-related scheduling as well as procedure tracking. We conducted this project at the UHealth Tower and the Sylvester Comprehensive Cancer Center here at the University of Miami. These are also the two primary places that I am working full-time as well. We wanted to identify the barriers in the user interface that prohibits appropriate scheduling of anesthesia resources. And on top of that, tracking these cases as they go through the perioperative flow from preoperative, intraoperative to postoperative, and understanding when cases start and end to help improve scheduling and staffing. We utilized the EPIC OpTime module in the perioperative setting, and the radiology departments use Radiant, which is the equivalent. Similar panels, but have similar issues as well. Again, the two aspects that I'm discussing here is, first of all, scheduling. Just a background of what the steps required. When a case is scheduled, there's an attribute that marks if a case needs anesthesia resources or not. If not, this case does not appear on our schedules and does not appear for us to even assign resources. So many times we will have a schedule for the day, and then we'll get a phone call in the morning saying, hey, why is there's no anesthesia providers in for this case? Well, it doesn't appear on our schedule. It was not booked correctly. So we try to investigate why that happened. When it comes to perioperative tracking, at the University of Miami, in many locations, especially in the main hospital, we use real-time locating system, RTLS, which are where patients wear these sensors, which you see on the right over here. And then we have the trackers across the hospital that will locate that patient in the flow, particularly in the preoperative locations, which operating room they're in, and then which spot they're in the postoperative setting. And that also helps us understand when a patient is in the room ready to get started and when they exit the operating room when the case is done. We also have manual entry that the procedure nurses within the operating room or the GI suites or any procedure room will manually enter times when the patient's in the room or when the procedure starts, when a procedure ends, etc. But there's many delays with that and dysfunction in terms of the RTLS system that we're using. So why do we think this is important? I'm an anesthesiologist. I'm also what we call a board runner. So I'm involved in the daily scheduling and daily management and directly and indirectly responsible for over at least 15 anesthesiologists per day and 45 nurse anesthetists and anesthesiology residents. So there's a lot of people involved, and ultimately it comes down to when do people get to go home, where should they be working, and that's very important for assigning adequate resources for the system. So ultimately, we need to know which cases need anesthesia and where those cases are at the beginning or the end, so we can allocate these resources effectively, efficiently, and make everybody happy. So now I'm going to go over the various sites and what we did via interviews to understand what the dysfunctions may be, starting with the main operating room. When it comes to resource scheduling, especially anesthesia resource scheduling, the main OR is probably the optimal functioning area of our system. All the anesthesia cases all the surgical cases that are booked in the main OR automatically have anesthesia resources requested through the EPIC system. And these cases almost always appear on our scheduling and assignment boards, so we can allocate those resources on a daily basis. We rarely see any issues in the main operating room area for when it comes to scheduling. However, when it comes to perioperative tracking, again, the main OR is one of the optimal places where we have all the trackers in place, all the rooms have them, all the operating rooms have them, all the preoperative and post-operative areas have them. However, there's certain ORs. We had new ORs that were built just over a year ago, ORs, we call them 15, 16, and 17. They're very close to the preoperative and postoperative areas. And they commonly the trackers commonly get confused on where the patient is, whether in the hallway or they're actually in the room. So those have to be manually fixed by the procedure nurses in the room. Another thing in this area is what we call the pool. Anytime the RTLS malfunctions, especially in the preoperative area, and we don't know what spot they're in, they're automatically placed in a pool. So there's multiple incidences of anesthesia providers or even surgical surgeons and surgical providers that go into the preoperative area and they're looking for their patient because they're in the pool, but they don't know the exact spot number. So time is spent looking for those patients. The next is the ambulatory OR, which is pretty much a mimic of the main OR, except there's only 6 operating rooms. It's a 1 floor below. Again, the functioning of the scheduling is as appropriate, just like the main OR, because there's a default setting for all cases in this area to have anesthesia requests. And they automatically appear for our scheduling on a daily basis. In terms of the perioperative tracking, again, they do have an RTLS system there as well. But again, the proximity of the different preoperative areas, patients are placed in this ambiguous pool as well often. So there's still issues with the RTLS. So manual entry becomes the way to correct this. Another very fast-paced area of the hospital is endoscopy and GI, where especially when it comes to perioperative tracking, we see a lot of discrepancy because of the fast-paced movement of all the cases. For a procedure nurse to manually enter when a patient is in the room or out of the room or the procedure started, they kind of chart that towards the end of the case instead of the beginning of the case. So they do also have RTLS hardware in all the GI rooms. However, a lot of them are outside of the actual rooms. So patients will be rolled by and they'll trigger the RTLS system and be in a wrong location. But when they enter the room, it doesn't really say that they're in the room until the nurses in the room manually enter that the patient's in the room. Again, when it comes to resource scheduling, we see many scheduling discrepancies in the GI suite, particularly because there's no default anesthesia resource request, although almost 90 to 95% of the cases done in the GI suite are with anesthesia resources. So this is something that we are looking into. All the outpatients usually are scheduled correctly with the anesthesia resources, and when it comes to scheduling inpatients, we see discrepancy in how those cases are scheduled. And when these don't appear, they don't appear on our list, and we don't know whether the patient's here or not, whether we need to see them or not, etc. This is an example of the manual entry panel that we have in the Epic. This is actually from the GI suite. As you can see, what the nurses have to do for manual entry of these events is find the tab. There's an events tab, and then they either have to enter the time or if they're able to click the now button whenever these events occur. Another site is the interventional radiology suite. Again, this is a hybrid location where they have many cases that require anesthesia resources and many cases that do not require anesthesia resources. So by default, they don't have a resource request, but usually the scheduling team at the interventional radiology is able to appropriately schedule with or without anesthesia and appropriately appear on our schedule for staffing. In the radiology suite, there is no RTLS, so everything for the procedure tracking is done by manual entry, like that screen that I showed you before. Usually, again, this is delayed because whenever the nurse has time, once a case is started, then they go back and fill in all the times and things like that. Cath lab, again, is very similar to the interventional radiology. Again, there's many scheduling discrepancies because many cases may or may not require anesthesia resources. And then certain cases that do need them don't have the request so this is a place where we get most of the phone calls every morning. Like, hey, you didn't staff this room with anesthesia. And then we try to follow up with that. And then for perioperative tracking, they do have an RTLS system there, but again, it's still very inaccurate in terms of the preoperative areas function fairly well, but when they go into the rooms, those are manual entry, which are usually delayed. MRI suite, they actually do a very good job of scheduling there, because whenever an MRI case is scheduled with anesthesia, it's a special procedure which automatically has the default resource request, but it is a hybrid location because they do many cases without anesthesia as well. There is no RTLS at this site, so everything about the procedure entry is done by manual entry, but there's no nurse there that actually does all this entry. So it's pretty much dependent on the anesthesia charting, on when the anesthesia charting started and when it ended, which can be improved. Another site is the heart station, or what we call where they do the transesophageal echo. Again, this team also is able to appropriately schedule anesthesia courses when required, because most of the TEs, when they do them with the anesthesia, and they have that type of procedure that requests the anesthesia request. But again, this is a hybrid location as well, because they do many other procedures in this location that also do not require anesthesia. Again, this place also has no RTLS. It requires manual entry by the procedure nurses, who are in the room, and they do a fairly good job because there's very few cases here that happen on a daily basis, and they're able to keep up with the manual entry of the charting. And last, we have the Sylvester Comprehensive Cancer Center, which is a combination of operating rooms, intervention radiology, radiation oncology. They have, in terms of the cases when they are booked appropriately with anesthesia requests, because I believe all the cases that are booked here have a default anesthesia request. However, there is no RTLS here, so everything is done by manual entry. This is the area that we see the largest scope for improvement, because the workflow here the manual entry is done pretty much at the end of the case. So this is a place where we are always asking, hey, did the case start? Is a patient in the room? When is it going to end? Is it closing? Etc. So this kind of summarizes what these issues are based on the different locations. I color-coded them with the positive and negative and neutral attributes, as in terms of the scheduling portion. For us, from the anesthesia team, we'd like to know when anesthesia is required. So the main OR and ambulatory ORs, they have the default setting for anesthesia requests, while the other areas do not. Scheduling errors, usually with the main OR and ambulatory, because the default exists, we don't see those errors. And then, like I said, TE, they do maybe between 1 to 4 cases a day. And we don't see many of those errors. But the other locations, we do see them. When it comes to perioperative tracking, the RTLS system, again, exists at the main OR, ambulatory OR, and GI, and the cath lab. But we see the errors still in all those locations, so it's still not a perfect system. Again, when I put manual entry, I put that as a neutral thing, because manual entry by default has the risk of delays. And then the manual delay, we usually don't see it in the main OR and ambulatory, because the RTLS system works fairly well, and the other locations not so much. So we went over, after doing these interviews with all the different departments on what their workflow is and how they entered this data, we figured there's 4 main aspects of improvement for user interfaces and user experience. Number 1, the easiest to implement would be just retraining, re-educating on the appropriate scheduling in the electronic medical record, along with the manual entry ways. And this can be provided by super users that are within each site, or they can be created into a training module in what our platform here is called ULearn, and required of all schedules and procedural nurses for appropriate usage. Again, this would require the support of IT to help understand how to create a module for this training, get it approved, and then be able to deploy it. The other solution proposal in the user interface would be to create the defaults and the mandatory fields. A perfect example of this is GI, where most, if not all, cases are done with anesthesia resources. They should, just like the main or an ambulatory, or have an anesthesia resource by default, unless otherwise removed. Hybrid locations, where we have the discrepancies, we suggest having a mandatory field where whenever a case is being scheduled, they have to physically or click, yes, I want anesthesia, no, I do not want anesthesia. That could trigger at least a thought process where, like, hey, wait, do we need anesthesia for this case or not? And make it a required field. The implementation of this definitely requires the support of the university IT department and perhaps Epic personnel to make these changes. Again, this all takes time, especially in the university setting. And then whatever those changes are, we can provide it into a training module in the ULearn system for everyone to learn. This is just an example of a screen where anesthesia is requested in a particular case, especially in GI. As you can see, it's in a tab, and it's they require area over here where it says anesthesia, and they choose an anesthesia type, and then they request a anesthesiologist and a nurse anesthetist in this case. And then over here, you have these two checkboxes, like, is that required for the case or not? Another solution problem, the third one, is automation. Again, this is what when we talk about RTLS, it functions fairly well where the hardware exists, but not without some of the issues. Relocating the sensors to be, such as in the GI suite, to be inside the rooms rather than outside in the hallway can help create more sensitivity in those trackers. Also, I know we were talking with Dr. Bloom about this earlier as well, about upgrading the hardware. The hardware we have in the University of Miami system is older, but it's still working with our Epic system. So there hasn't been much push to improve it. And then again, this requires convincing decision-making administration to approve capital invested in upgrades or getting additional locators in the procedural areas that don't have them. Again, implementation of this would also involve the front-end configuration with IT and Epic to make sure any new hardware or additional hardware is incorporated into the system. And the last is interface design. The Epic Anesthesia OpTime module for intraoperative case tracking, we have a thing called what we call a hot button, where we can click that same button multiple times for each event in succession. In any anesthesia case, you have a portion of it where the anesthesia start time, and then when we start collecting data, when we induce or start the anesthesia medications, and when we protect the airway. So for each that, we just have one button that we keep clicking in succession. We suppose that something like this could be applied to for the procedural nurses as well. Instead of having to go to a tab, put it into a manual entry, either adding a time or clicking the now button in a small set, looking for which section they're at to click that one. A hot button could be very easy. That same button can be clicked in succession, which would make it easier and probably more less delay to click at. Like a patient comes in the room, the nurse can just go to the computer screen and just tap the screen and say, patient's in the room. And then that same button they can push for the procedure has started. Again, the implementation with this would require IT and Epic support along with administrative approvals, because it would be an interface change. And as we have learned from previous times, Epic is not easy to work with, especially in major interface changes, but it's not impossible. This is a screen of an anesthesia chart where we have this hot button right here where it says extubation, where that's the one button that we click for each of our intraoperative events. So in conclusion, implementation of all this would require a lot more time and a lot of hurdles with IT and Epic personnel, which we did not get time to do with this project. But while conducting these interviews with all the different departments, just bringing it up, especially when it came to scheduling and like, hey, it would be nice if all your cases that needed anesthesia had the anesthesia request created. There's one day just last week where the entire GI suite with over maybe like 60 or 70 cases, all of them appeared on our list. and I one of our colleagues there, Fred, who's a nurse manager there at GI suite, he was very proud of that fact as well. Again, we use for this interviews, I try to use contextual design to put myself in their shoes, like what they go through, the schedulers and the procedure nurses, what they do when they come in the room, what they do when they schedule cases, and I try to put myself in their shoes as end users. The user interface, user experience is vital in any system infrastructure, and we'll definitely need to focus on the operability by the end users, not just functionality. And the focus of this project to improve scheduling with anesthesia resources and to improve the tracking. And this would help improve workflow, improve the user experience, and increase efficiency of staffing, especially from the anesthesia perspective. The next steps in this would be to try to implement some of these solutions and then investigate measurable outcomes. And this would could include measuring the incidence of scheduling errors before and after implementation of any of these, measure the actual perioperative event tracking delays via manual entry before and after the implementations, and also measure incidence of RTLS errors, and then anesthesia resource allocation metrics. That's like, what time are people getting in? Are people starting cases on time because they know where the cases are? Are we adequately staffed every morning? Are people, especially when there's a lot of shift work, are people leaving on time, etc. So those are the next steps that we would be looking forward to. Thank you.